Hello and welcome to the module on NSAIDs and leukotriene inhibitors. Today we're just going to be talking about how your body mounts an inflammatory response, and that's going to be through two pathways. It's going to be through the COX pathway and the leukotriene pathway, which we're going to be discussing today. We're also going to be talking about drugs that inhibit this inflammatory response. Here's the inflammatory pathway we're going to be talking about today. It's going to be through the use of membrane phospholipids and how we turn these membrane phospholipids to prostaglandins, thromboxanes, and other inflammatory responses like leukotrienes. These are all known as eicosanoids. Now, the first step in this process is going to be the use of inflammatory cytokines. These cytokines activate NF-kappa B, and this NF-kappa B causes an increase in expression of phospholipase A2. So you've got phospholipase A2 over here that turns your cell surface membrane phospholipids into arachidonic acid. Now, arachidonic acid is going to be very important because that's the crossroads of all this inflammatory response. We can all inhibit this through the use of glucocorticosteroids, which just inhibits this gene right over here. Moving on, arachidonic acid has three different pathways that it can take. This arachidonic acid could go through lipoxygenase, the 5-lipoxygenase pathway, and that's going to make leukotrienes. And when I say leukotrienes, I want you to think more inflammation and bronchoconstriction of your airways. That is because that's where most of the drugs are going to be working on. And the drugs of choice are going to be Xylucas, Montelukast, and another one Ziforlucas. Finally, it can go through the COX pathway, and the COX pathway actually divides into two different ones. There's going to be the COX-1 and there's going to be the COX-2. When you say COX-1, I want you to think more of thromboxane, and this thromboxane, or also known as thromboxane A2, is going to be very important for clotting. Another thing that the COX-1 pathway also does is going to be mucus production. So you want to think of mucus production as well with COX-1. Most NSAIDs actually affect both COX-1 and COX-2. So they're going to actually inhibit both of them, and that means that you're also going to get an inhibition of prostaglandins, and that's the number one use that we like to use them for, because that reduces the inflammation and it also helps with a little bit of pain as well. Now, glucocorticosteroids are going to be one of the more important drugs that you're going to take. How do you know you're going to be talking about a glucocorticosteroids is that most of them will end in zone. Some of them will end in lone, but it's very similar sounds, just like betamethasone, cortisone, prednisolone, or prednisone. So how do they work is that they bind into an intracellular receptor, and this intracellular receptor will inhibit NF-kappa B gene. And as I said before, NF-kappa B gene is going to be important for the expression of phospholipase A2, amongst other things. So if you can inhibit the phospholipase A2, you don't even make arachidonic acid to begin with, and you get an inhibition of the leukotrienes, the prostaglandins, and the thromboxanes all at once. Now, with something this powerful, you can expect a lot of adverse effects. More specifically, it's going to cause it in your bones, and it's going to cause it inside of your muscles, and it's going to cause it inside of your skin. So that tends to be the number one reasons. But let's go into a little bit more detail about that. Why does it cause weakening of your bone? It's through the inhibition of osteoclasts. Osteoclasts are just specialized macrophages that are inside of your bone, and they're very important for bone remodeling. So if you get an inhibition there, you don't get a remodeling of your bone, and eventually your bone just gets weaker over time and eventually starts collapsing on itself. Now, if it starts collapsing on itself, you can expect avascular necrosis of the femur of the head. There's a lot of pressure right over here on your femur from just the weight, and this eventual just tiny collapsing of the head can eventually make no more room for arteries, so you get an avascular or no blood necrosis of the femur of the head. Finally, another one of the bigger diseases is going to be Cushing's syndrome. This is pretty much Cushing's syndrome right over here. It's expressed with moon facies, so you get puffy moon, you get that fat pad on your back, you get the striae from the thin skin, and just overall, you should be able to recognize this. They'll have pretty thin arms and legs because they have a muscle loss, but they'll also have skin loss, so you want to look for the striation. And the moon face and the buffalo hump are pretty much given. Now let's talk about non-selective NSAIDs. These are probably one of the more popular drugs on the market because they're so often used over the counter for pain and inflammation. So you probably recognize aspirin, ibuprofen, naproxen. Maybe you don't recognize naproxen, indomethacin, or ketorolac, but it's still very important for you to memorize all of them. And you should know that they inhibit both COX-1 and COX-2. So through the COX-1, you're going to get a blood thinning effect, and that's really good for people who suffer from MIs. And through the COX-2, you're going to get an inhibition of the prostaglandin, and that's going to cause a decrease in inflammation. So that's going to be very good for people who are suffering from pain or inflammation like an arthritis. But what's more important is going to be the adverse effects of these drugs. These are probably one of the more heavily tested drugs because they're so commonly used. And when you think of adverse effects, you want to think of it inhibiting mucus production. And this can cause peptic ulcers because your stomach really needs a lot of mucus to protect it from the acid. It can also cause a blood thinning effect, which can be good for people who suffer from MI or at risk of suffering from an MI or stroke. But if you're suffering from GI bleed in older patients, this can be very, very life-threatening. Finally, it can cause two different things with the kidneys. So you probably didn't realize that prostaglandin also causes vasodilation. Now, this vasodilation can be important in the case of inflammation to allow white blood cells to get into your interstitium, but this vasodilation is also important for keep maintaining blood flow, renal blood flow. So if you take a COX-2 inhibitor, like any of these over here, or just any COX inhibitors, any of these NSAIDs can actually cause renal ischemia because your body is no longer capable of maintaining blood flow to the kidney through vasodilation. Finally, it can cause interstitial nephritis. Don't be scared of this word. Interstitial just means between the cells, and nephritis just means inflammation of the kidneys. So you just want to think of it building up between the cells of your kidneys or in the inside of the interstitium, and it can kind of cause an allergic reaction. So you want to think of everything that's associated with an allergic reaction, kind of like IgE and eosinophils and whatnot. And this allergic reaction can actually pretty much kill your kidneys. Now, moving on, let's talk about specific NSAIDs that are often tested. Acetaminophen is often tested because it's very different from the other ones, and it's different because it's actually fat soluble rather than water soluble. And every time I say fat soluble, I want you to think of two things. I want you to think that it can cross the blood-brain barrier, and it's more likely to be metabolized by the liver. And this actually raises some new implications for this drug. That being, it reduces fever and pain, which is more of a central nervous response to inflammation. And it also can cause a lot of damage to your liver. In other words, hepatic necrosis. As hepatic necrosis is due to the buildup of NAPQI, and that's NAP, N-A-P-Q-I. And that builds up. You're going to talk a lot about that when you get into the GI module. But the good thing is that it actually spares the kidneys. Now, it's important for you to know that children or the pediatric population in general have smaller kidneys, so you don't want to use aspirin or ibuprofen to help them with pain. But Tylenol works just great, and that's why I showed you a picture of a child right here. It says children's Tylenol, and it's okay because it spares their kidneys. Something that I didn't mention about Tylenol is that it does not reduce inflammation. It just reduces the pain caused by the inflammation. It doesn't reduce the inflammation in general because it only works really in your central nervous system. Now, aspirin. Aspirin is going to be one of the more heavily tested ones as well because it's unique. It's unique because it's irreversible. And what I mean by irreversible is that the platelets just become useless. It completely wipes out the platelets that are affected by it. And as you've probably learned, that platelets take about 7-8 days to reform inside of your blood, so they last about 7 to 8 days. So pretty much someone who's on aspirin cannot go to surgery for about 7 to 8 days because their platelets aren't working. If you cut them open, they'll bleed forever. Another thing that asthma may cause is going to be it may induce asthma or aspirin-induced asthma, and we'll talk about that later on. All right, celecoxib is going to be the only selective NSAID that you need to know about. And it's pretty easy to memorize because its name sounds like selective COX inhibitor, celecoxib. And what you need to know is that it inhibits COX-2 only. So you can expect that it's going to stop inflammation, but it wouldn't have the clotting effect. So you would imagine that you would inhibit the COX-2 so you don't get inflammation, but you can still continue having the clotting effect and you can still continue having mucus production. This is really good for patients that have peptic ulcer disease because it doesn't inhibit their mucus production, or a history of GI bleeds because it doesn't make their blood thinner. However, the side effects are exactly what you would expect the opposite to be. It actually causes thrombosis. And this thrombosis is because, if you can imagine arachidonic acid, AA, instead of being allowed to go through here, it's going to be all shunted all through the COX-1, and you're going to have an increase in thromboxane. So you actually get a hypercoagulable state somewhat, and they've actually found that you have an increased risk of myocardial infarction. And that's just because of the shunting effect. Also, something you need to know about it is that it's a sulfa drug. I showed you a picture over here of how sulcoxib looks, and here's the sulfa group. So you would expect hemolytic anemia with certain patients that are sensitive to sulfa drugs. Now, leukotriene inhibitors. There are mostly two classes and three drugs that you need to know. The first one is going to be xylutone, and this is going to be the one that inhibits the 5-lipoxygenase. This is important because 5-lipoxygenase is needed to make leukotrienes, and leukotrienes is needed for bronchial inflammation. So if you don't have any leukotrienes, what happens is you get no inflammation and no bronchoconstriction. The other two that you need to know about is montelukast and zafarlukast. They both end in lukast, and so that makes it pretty easy to memorize. And what you need to know is that they inhibit the leukotriene receptors, so you don't get bronchial inflammation or constriction by inhibition of the receptors themselves. Now, why are these used? It's mostly just for one thing, and that's going to be aspirin-induced asthma. As we talked about earlier, aspirin-induced asthma is what happens when aspirin pretty much inhibits all of the COX pathway, so all the arachidonic acid gets shunted into the 5-LOX pathway. And this shunt actually causes a lot of bronchial inflammation and symptoms of asthma due to leukotriene production. As for the leukotrienes, you only need to know 4 of them, and they're usually numbered LTB4, LTC4, LTD4, and LTE4. So after you've memorized these, the only one that you need to know specifically is going to be LTB4. And LTB4 is important for neutrophil chemotaxis. So I just remember that LTB4 comes before the neutrophils. So it's important for neutrophil chemotaxis. The other 3 are just used for bronchodilation. Now, how are you going to use this information? It might seem like a lot right now. So I would just highly suggest that you draw out the physiology of these eicosanoids. Just learn where they fall into place on the flowchart and draw out where the drugs, each of them, act. This will help you out in just visualizing it and grouping them together. After you've got them grouped together very well, what you want to know is you want to learn the unique stuff about each one. And this is especially true just for the NSAIDs in general, like aspirin. It's an extremely potent, irreversible blood thinner. So you can't have surgery for 8 days. Acetaminophen being fat soluble, crossing the blood-brain barrier, and being metabolized in the liver, and celecoxib having less bleeding and more clotting effect, and also that it's a sulfa drug. As for the steroids, you probably want to learn as much as you can about them, from the mechanism to the adverse effects, because they're very heavily tested. And that's just because that they're used in so many different modules for so many different diseases. Now, the leukotrienes are pretty easy because the patients are almost always presenting with airway inflammation, and that's usually secondary to aspirin. They'll mention something that the patient is taking aspirin, or they'll mention that the patient has a history of a stroke or an MI, so you would expect someone who has that history to be currently on aspirin. Now, here's a question to help us kind of how it would be asked in the test. It'll probably tell you about a patient that's coming in with arthritis, maybe sometimes gout, and you being the smart medical student that you are, you're going to have to figure out which one of the NSAIDs that you're going to use. So if they have a history of MI, aspirin would be really good because of its blood thinning effect. If they have a history of GI bleed, you want to probably use celecoxib to avoid further GI bleeds. If they have a history of chronic kidney disease, or in children with tiny kidneys, you probably want to use acetaminophen, which doesn't really help with the inflammation, but it definitely helps with the pain. And finally, NSAIDs, if it's just completely resistant, you want to bring out the big guns like the steroids or the glucocorticosteroids such as prednisolone.